Now, thank you very much for coming out in force this evening. You're all very welcome. It's great to have such a good turnout. The last time I addressed Arthritis Ireland Kildare was pre-pandemic, 2019. And I did look back at the talk, in particular at the flyer for the talk. So this one says it's led by me, whereas the previous one said talk by or lecture by, you know. So it's obviously changed and we need your involvement. So I have some fantastic questions here that I will address during the course of the evening. So I'm an orthopaedic consultant across the hospitals on the bottom. Normally when I'm talking in Kildare, it's to the south of the county. And we're on the home turf in Naas, but I realise for many of you here it's Connolly Hospital, Kappa and the Hermitage Medical Centre, perhaps some maybe a little further afield than those. I'm in Tala and Naas Hospital since 2013. I have a mixed trauma and elective practice, so I may have treated some of you or your families over the period. I trained in both Ireland and then in Baltimore in the US, and I graduated in UCD. In fact, 2 weeks ago, I was I was about to say Kildare, but it was Enfield. It was for my 20-year college reunion. So the years have gone on, you know, so yeah, 20 years since graduation. So great to see you all tonight. It's definitely an evening for the ladies. Obviously, there must be football on at home. Congrats to the few gents who made it out this evening, you know. So the soccer, I don't even know who's playing, but there must be soccer on at home anyway. But no doubt you'll go home and impart all your knowledge to them and get them into the clinic, okay? Obviously, I was reading the literature in advance of preparing the talk, you know. And one of the measures that's extremely effective is group education sessions, you know. So if people know the condition that they have and how to manage it, it's a big step on the way to successfully living with something like arthritis, you know. So that is key. So education and lifestyle modification are two of the key words that will probably come up during the talk tonight, and they are the background to a lot of what we're going to say. So these are a few people who might come into the clinic with hip pain. Those who are astute will notice that this is the same picture as is on the flyer, only it's the other hip that is being illustrated. So you can see this gentleman here is locating his hip pain to the side of the hip, and we get a lot of people who will complain of that. This gentleman here is locating his pain perhaps to the back of his body. It's most likely that his pain is coming from his lumbar spine or low back. And in low back pain is exceedingly common, 50, 60, 70 years of age. And it does account for a lot of people. And low back pain often radiates down to the buttock area. So if you've got buttock pain, the chances are it's as likely to be coming from your back as from your hip. If you're in the group of patients who have groin pain, now this gentleman is younger and he may have a soft tissue injury to his hip, but the classic location for hip pain, that is arthritis, is in the groin, okay? So a lot of people don't know that, they think it's in the buttock area. If you've got groin pain, you probably have hip arthritis, okay? This lady here, the pain is a little higher, it's in the low flank, and it's likely that her pain isn't related to her hip. It's a little too high perhaps for that, okay? But it may be muscular in origin, in sympathy to a process that's going on in the hip. So when we meet you in clinic, you know, we will always take a history. We'll ask about the location. We'll ask if the pain radiates. So about 30% of patients, the pain will run down the front of the leg towards the knee. And again, that's very classical of hip arthritis. So if you've got groin pain running down to your knee, you may even come into the clinic thinking there's a problem with your knee. So we would see this at least maybe once a week. And you know, we're telling patients, actually it's your hip. You know, you don't need anything for your knee, it's a hip replacement that you need. We're always keen to iron out how long the pain has been going on for now. Obviously with waiting lists, most patients have well-established diagnoses by the time we meet them in clinic. They've had an X-ray and they're waiting to see us for treatment options. But you know, some patients will have short duration of symptoms, and it may be possible to provide conservative measures like physiotherapy to reset the hip, for want of another word, and to provide simple analgesia, and their pain may settle back to the level it was before it got really bad. When we're talking to patients, one of the key features, and this applies to both hip and knee, is, does it wake you from your sleep at night? So if you're in this room and you know you're going to go home and have a sleepless night, that's really important for us to be aware of, because there's a major impact on your lifestyle. And then you fall into the category of patients who should consider joint arthroplasty if other conditions are met. So if you're awake at night, in particular if you struggle to get back to sleep after wakening, then that is having a significant impact on your life. We always ask people how far they can walk and whether they need assistance when walking. So if you're walking and you can only get as far as the shops, well then you might need something done for your hip. If you can't get to the shops at all, medical conditions permitting, you probably need something done. Rotational movements around the hip can cause discomfort. So putting on shoes and socks and getting into and out of a car are two other questions that we ask people. So if you're struggling in those activities, again, it may be your hip. If you've changed the car because it was too low or too high, they again are signs that, perhaps it's the hip that's driving that. We're also keen to know what pain relief you take. So are you taking anti-inflammatory medications, or are you taking paracetamol? And if you're taking medications that are going to make you drowsy, like opiate-based analgesics, so the classics would be OxyContin or Oxynorm. Some of you may have seen the programs on these. They are highly addictive, and they will have sedation as one of their side effects. So for patients who are on excess analgesia, it may be sensible to consider intervening surgically. Now, what does an arthritic hip look like? So your hip is a synovial joint, and it's lined by cartilage from within the hip. And the cartilage there is purple in color. Normally it's white. In arthritis, the cartilage becomes worn. You get holes in it, so that's fissuring. It wears away. You get cysts in and around the joint, and the space in the joint and the fluid in the joint change. So the joint space reduces, and in general, you can either have an increase of fluid, and that stiffens up the joint. And the capsule will also thicken as part of the process. Diagnosing hip arthritis is difficult because there are a number of overlaps, as we mentioned, with the lumbar spine. So this is looking at a patient from behind, and all these conditions here can masquerade as pain in the hip, some of which can be treated by physiotherapy. So just to give you a couple of them, we would have sacroiliac joint pain or dysfunction. We have tendinopathy of a number of tendons, with pain from muscles, the gluteal muscles, gluteal tendinopathy, gluteal tears. A lot of them will give you pain on the side of the hip or in the region of the buttock. Very few of the conditions illustrated here give you pain in the groin. And that's why groin pain is pathognomonic of hip arthritis for the most part. So let's have a look at just a case here to show you maybe what this patient's journey was. So he's a 59-year-old male, pain in the left groin. It's been going on for a couple of years, and it radiated down as far as the knee. So classical presentation. The walking distance is reduced. He's getting pain at night, and his difficulty putting on shoes and socks. Now, this is a normal hip x-ray, so this isn't this patient's x-ray, but you can see on the normal hip x-ray that the joint space is still visible on either side, and there isn't a picture of osteoarthritis there. just show you on the next x-ray, the joint space is reduced. There are osteophytes in particular here at the inferior margin, and there are some cysts in particular in the acetabular area. So this patient has osteoarthritis. Now, if you're getting an x-ray for osteoarthritis, we always tell GPs at meetings and that the patient should be standing for the x-ray, okay? So, you know, if you're getting an assessment of whether your joint space is reduced, you need to be standing, otherwise it'll appear as if it isn't, okay? So it's always a standing x-ray of the hips. So this hip is normal. You can see the joint space is relatively well preserved. This one, joint space is reduced. Now, he is a candidate for a hip replacement. It's likely if you examine someone like that, that they won't be able to extend their hip fully or bring it backwards. So when they walk, their position for walking is slightly hunched over. And this is an uncemented hip replacement. So this is the type of one that we're putting in this week. This is the stem that goes down into the femur. There is a cup. There's a plastic liner. And there is a head. And the head is made of ceramic here, with pink ones and blue ones. No, they're all pink. So the guys get a pink one too, okay? They used to be kind of a shade of yellow, but they're ceramic. They're all made by one company, more or less, for all the manufacturers. That is a very low wear rate. It's also possible to get a good outcome using a stainless steel or metal head on a plastic bearing, okay? So, but that's how a hip replacement is made today. This is an uncemented hip replacement, so you can either have a cemented hip or an uncemented hip. This is uncemented. And this one has a collar on it, so you can see the collar here. That provides extra strength and resists rotation. The outcome of cemented versus uncemented hips are pretty much the same. There's certainly a trend towards an increased number of sockets that are uncemented or press fit. And then on the stem side, it's about 50-50, probably a choice between cemented and uncemented, and both work equally well. There's excellent evidence for both. So here is his hip replacement completed, and you can see that the ball is in the center of the hip where the hip originally was, and the stem, you know, is filled by the press fit stem. And if we measured it, the leg lengths there are about equal. So if you get a hip replacement, there's always a little chance that your legs will be lengthened, sometimes for stability, to reduce the chance of the hip dislocating. But the lengthening is, you know, normally less than 1 centimeter and normally not something that's discernible to patients. Once it goes above about 2 centimeters, you would be aware of it, okay? Now, if you had a short leg on the opposite side, that may, you know, be something that creates a difference. But for most patients, they're starting with 2 legs the same length, okay? Now, people often ask us, you know, you're told you need a hip replacement, but I don't really feel it's bad enough yet for a hip replacement. So what's out there as alternatives? Well, you know, there is injections that you can get into the hip. Some of the disadvantages of injections are that they are best used diagnostically in the hip. You know, if there's a doubt that you have arthritis, an injection into your hip joint, that's an intra-articular injection, may be a good idea. If you have a problem with the tendons around your hip or your trochanteric bursa, then injections into that area may help. So it's got a role in early osteoarthritis. They're useful as a diagnostic aid, but sometimes if we inject your hip today, in 2 weeks it might be back to normal. So you might get 2 weeks of pain relief and it would tell us that it's your hip that's the problem. But, you know, the duration of benefit would be only 2 weeks. So it's not a great therapeutic intervention. By and large, its role is also there in younger patients, but we really come back to the idea that they need to modify their lifestyle. So if you have early arthritis, which is also known sometimes as femoroacetabular impingement, it is probably preferable if you can manage your symptoms with lifestyle modification, avoid the activities that give you that hip pain, take simple pain relief, rather than proceeding to an injection into your hip joint. There's definitely a role for physiotherapy, there's definitely a role for weight control, and there's definitely a small role for injections. But principally, the treatment that we give patients for the most part, once you have established arthritis, is a hip replacement. There's probably no lower age limit that you have or can have a hip replacement at, but a lot of hip replacement would be done in patients between about 50 and 90, I suppose, with smaller numbers in the 50s and 80s than in the 60s and 70s. Above 90, we definitely do hip replacement. I've seen someone today who's 93 and they are on the list. Below 50, we do hip replacement. I suppose in the 40s, we do hip replacements in reasonably large numbers. But patients undergoing hip replacement at that age would have to be aware that, by the time they would reach 60 or 65, they would potentially need a revision of their hip replacement, okay? So that's something to be aware of. Now, everything we've spoken about there probably relates to osteoarthritis. So perhaps some people in the room have rheumatological conditions, and the surgical treatment for the two conditions is the same, although your medical treatment workup and options, including pharmaceutical agents that they might give you, might be slightly different, okay? So some of you may have seen a rheumatologist and be managed for systemic joint polyarthropathy or pain affecting multiple joints. Now, if you were undergoing a hip replacement tomorrow in Ireland, you will likely have it under one of three surgical approaches. And we often get asked which approach is the best and which surgeon should I choose who does a particular approach. I think the first thing to say is be confident in your choice of surgeon, pick the surgeon, not the surgical approach, okay? So, one surgical approach isn't necessarily better than the other. All have merits in the hands of an experienced operator. The three commonly in use in Ireland would be I suppose to start here, the anterolateral approach. Apologies, the colours mightn't be great on black. But the anterolateral approach is a traditional hip approach. The muscles get cut in it, and there is a risk that you could walk with a slight limp after the operation, okay? So for that reason, there has been a shift in Ireland over a number of years towards a posterior approach that's into the back of the hip, and that offers the advantage of it doesn't end with you having a limp, okay? And then there's also an anterior approach to the hip, which is a muscle splitting approach, also known perhaps as a bikini type incision to your hip. And that's putting the hip into the front, okay? And there are merits to each. There are complications with hip replacement. So about 95% of people undergoing hip replacement will have a good outcome. There might be up to a 5% complication rate. Now, each of the complications is only 1 to 2%. One of the complications is dislocation or popping the hip out of the socket. And probably, if you are with an experienced surgeon, whichever approach they're using, they will mitigate against that complication, by setting the hip correctly in the socket, okay? So, we always get asked, which approach should I have? I do, for the most part, a posterior approach. There is a demand for anterior approach, and I will probably transition to offering both in early course. But patients in general are very happy with the posterior hip approach, and it is used widely internationally. Now, that's our talk on hip conditions. Okay, so I have knee coming up. We did have a couple of questions maybe on hip. So I should have divided the questions into hip and knee. So the first one was, is it possible to have both hips operated on at the same time? So assuming bilateral hip replacement. So yes, it is. I did it this week. So proof of the pudding there for you. Someone has had it on Monday, and I will see them tomorrow, and we'll have to see how they're getting on. But in general, you might be in hospital for 1 day longer. It represents a good treatment option for patients, say, I'll give you an example, someone who's in farming or that, so they want a defined period of time out and then they want to get back without having to come back for the next hip 3 to 6 months later. Someone's trying to get in. The time span, I suppose, if you had one hip replacement, how long should you wait before having the second hip replacement? And I think the answer to that is probably about 3 months is the current recommendation. It takes about 6 weeks to get over a hip replacement, 10 weeks maybe to return to things like golf, 4 weeks to return to driving. But 3 months when they've looked at it lately is the recommended time to have the second hip, but sometime between 6 weeks and 3 months later. How long does hip replacement last? Well, the hip replacements that go in today will last around about 15 years, 90% of them. And of the remaining 10%, 80% or so of those will continue to last for a further 10 years. Okay, so it's quite high. What has changed is the plastics that are used. So we used to see if your hip didn't get infected, it had quite a high wear rate, and the plastic wore in the hip. Similar situation pertained to knees. They have got better in terms of manufacturing the plastics, and it's now recognized that they should be on a shelf for a shorter period and they shouldn't be left to age outside the body. So that's all factored in the supply chain, and we're not seeing wear rates like we traditionally did in hip and knees. Okay, so hip replacement certainly lasts. Now the answer to that question is also a bit of a trick. If you need a hip replacement for quality of life improvement, you shouldn't hold back on the basis of your age. So there's no point being in pain from 45 to 60 waiting simply because it'll last you then for 15 years or beyond. You might as well go and have it. Okay, so they were the questions just in relation to hips. I think there might be 1 or 2 in relation to knee. So maybe we'll go ahead and talk about the knee, and then we can pause for questions if that's okay. Can I ask, in the room, how many people are contemplating perhaps getting hip or knee surgery, hip or knee replacement in the next 6 months? Okay, so there's definitely a number of hands who the content of the talk, I suppose, is of immediate relevance, and best of luck to you all. So here we are. We've moved on to the knee, okay, and knee replacement. So knee pain in general is, in this case, can be caused by arthritic change. Now, as you get older, particularly once you're over 45, if you have knee pain without mechanical locking or catching symptoms, it's most likely that you have a degree of arthritic change. And you can have it in a few areas. You can have it between the femur and the tibia. Those patients tend to get pain on standing for long periods. You can also have it in the groove here, between that and the kneecap, which isn't illustrated in the picture. And that tends to be what we call patellofemoral arthritis. And patellofemoral arthritis is something that affects you when going up or down stairs, or when going up or down a hill. In fact, more so when you're going down than going up, okay? So if you've got patellofemoral joint pain, the treatment is slightly different, but at the end of the day, there is a role for knee replacement. So again, we're taking a history and we're looking, is the pain something that is mechanical or does it catch or lock? If it doesn't catch or lock, it's likely it's arthritis. If it's catching or locking, it's possible that you have a tear in the shock-absorbing cartilage, which is called the meniscus, okay? They're the circular-shaped cartilages within the knee. Again, we're looking for your duration of symptoms. We're looking for night pain. We're looking to see if you have pain going up or down the stairs. In particular for patellofemoral joint arthritis, so arthritis at the front of the knee, weight control plays a major role. So if you can reduce your weight by 1 kilogram, it'll have the effect of reducing the weight across the patellofemoral joint by up to 3 kilograms. In other words, its force is reduced by 3 times the weight which you lose. And, you know, obviously we have to make sure it's not your hip if you're coming to us with knee pain. So about 30% of patients, there's an overlap hip to knee. When we examine the knee, you know, the knee may be swollen, okay? So you can see here, this knee is bigger than the opposite knee. And there's a fullness. Normally on the outer side of the knee, there's a concavity just above the kneecap where you can run your hand and it feels like a hollow. If you have an effusion in your knee or fluid in your knee, it'll stick out and it'll be prominent, like in this patient. So here's a patient going down the stairs, and you can see that they have a painful knee. Now, there are a number of other conditions, just like there were around the hip, that can cause knee pain that aren't necessarily knee osteoarthritis. So it's a busy slide, but you can have pain in the iliotibial band. So that's a band of muscle running from your knee to your hip. You can have pain either side of the kneecap on the inner aspect or outer aspect of the knee. It can be arthritis. If, however, it is catching or locking, it can also represent a meniscal tear. There are a number of conditions that can affect your patellar tendon. That's the tendon running between the kneecap and the tibia bone. Some of these conditions affect younger people and adolescents, but you can have jumper's knee, instability of your kneecap, so your kneecap is prone to dislocation, or you can have Osgood-Schlatter's disease, again, condition of adolescence. The inner aspect of the knee, or the medial side of the knee, well, that's probably the commonest place to get pain that is osteoarthritic in nature. In most patients, it's the inner aspect of the knee that wears first, and that's where they develop the symptoms of osteoarthritis. Pain that's worse walking down the stairs or up the stairs, well, that tends to be related to your patellofemoral joint or between your kneecap and your femur. And it can be very disabling. A lot of people have that, and it's difficult to manage. Initially, we'll always try conservative measures for that condition, but knee replacement is also successful at managing that. The National Institute for Health in the UK have their guidelines, so this is the NICE guideline. And the advice to GPs in the United Kingdom is if you are over 45 years and you have pain with activity, you don't get morning stiffness or morning stiffness that lasts greater than 30 minutes, then they need to be referred onwards for an orthopaedic opinion. Because they're concerned that you will get functional limitation and that your pain will worsen. So that's making the diagnosis of osteoarthritis clinically. A lot of patients describe startup pain. So that's pain, you might be sitting here and at the end of this evening's lecture, you might struggle to get out of the seat. And that may be related to your knee, or that you've fallen asleep during my boring talk. But if it's related to your knee, if it settles in a few moments, that's what we call kind of a startup pain, or settles by the time you reach the car park. Obviously, if it's ongoing in the morning and lasting more than 30 minutes, that may overlap with an inflammatory arthropathy. So here's some knee x-rays. So again, remember, these are standing x-rays. They're weight-bearing x-rays. So we're looking at the alignment of the knee as you stand, but we're also looking at your joint space either side. And what you see here, these are relatively healthy knees. The joint space is slightly less on the inside of the left knee when compared to the right knee. So on the right-hand side of the screen is the left knee, and you can see it's just a little bit tighter, and that would be early osteoarthritis. This is the difference between a weight-bearing and non-weight-bearing x-ray. So this is someone who's had an x-ray with them lying in the bed, and we can still see their joint space, whereas when they are standing, that is reduced. And the reduction again is consistent with an arthritic knee. X-rays have an advantage over MRI scans, but we frequently get people with MRI scans as well. So this is an identical patient. This is their MRI scan, which shows the cartilage is relatively well preserved. But when we look at their knee X-ray, they have some arthritic change there that's probably better visualized or appreciated on the X-ray. Okay? So, a weight-bearing X-ray is probably the most useful investigation that we can get to tell you if you have significant arthritic change in your knee. We also take X-rays looking sideways at the joint. So these are what we call lateral views, but they're taken looking that way. And they show us the joint of the kneecap with the femur. So this is the femur bone, and this is the kneecap or patella. So you can see there's a joint space between these two. The joint space is reduced between the next. And then over here, it's almost completely obliterated, and there are also osteophytes above and below the patella. And we see, in the first patient, there's no osteophytes at the back of the knee, whereas in the second and third patient, there is osteophytes at the back of the knee. So, busy slide, but I did include this just to show that, community health interventions do play a part in how patients manage their arthritic conditions. So this is in London, patients were referred to a physiotherapy-led program. And after attending, 77% of people were happy to self-manage their condition, and only 10% needed further review with the physiotherapist. And then, Staffordshire, this is a 6-week program, education exercises to improve strength or fitness. 52% of people reported reduced pain scores, 95% had improvement in one functional measure. So there are similar programs in areas, and I know you have a program here in the Glen Royal, I think, for exercises, for the sitting exercise program, I think, yeah? And that likewise, there are programs that are, have been established and are supported in part by the HSE. So Exwell Medical would be one example. I don't know if anyone has attended at that. They run physiotherapy classes, largely in the Dublin area, but I think they may have some venues pushing out this way. At least City West is one. And they focus on access to exercise classes for patients. And I know the HSE are now supporting attendance at those for patients. So, Exwell Medical is something that was established by a consultant in sports medicine and has expanded. So, community intervention or group classes certainly work in helping patients manage mild to moderate symptoms of osteoarthritis long before they need to see an orthopaedic surgeon. Now, we have a ladder of treatment for knee osteoarthritis. So we tend to start at the bottom rung, and the knee replacement is way up at the top rung of the ladder. So the first thing we'd say to you is, if you have knee pain, probably some simple pain relief is good. So either one of two agents. Paracetamol is the one with the most evidence for it. A lot of you may say that it's like taking Smarties, because we often hear that back to us in the clinic. There is good evidence that it works, and simple non-steroidal anti-inflammatory drugs. So it may be Nurofen, it may be Vimovo, it may be Difene. They all will have a role. Some patients will benefit from the use of gels for symptom control, something like Etaflam gel or Difene gel. Weight control. So we'll always advise people to reduce their weight insofar as possible to a normal BMI. There's a role for attendance at a physiotherapist. Now that can either be an individual session or, as we've discussed there, a group type session. There is a benefit to attendance at exercise classes that aren't run by a physiotherapist, or working on building your muscle strength yourself. It's important, you know, for the knee that you're building, say, your quadriceps, your hamstring and your gluteal muscles. Some people get a pedal set or static exercise bike. So some of you may have one of these at home, and using this while you're watching the television or reading the paper, you know, will help to build up your muscle. I don't see anyone has brought one tonight, but they may have. They may be pedaling away there at the back and building the muscle. So, you know, the stronger anti-inflammatories are probably there as well, halfway up the ladder. So diclofenac and use of gels. So these would be medications maybe prescribed by your GP. Unlike in hip arthritis, there is good evidence for injections for controlling your knee pain. Now, for mild to moderate osteoarthritis, injections certainly work. They also work in symptom control for patients who aren't keen to undergo a knee replacement. In terms of what can be injected, so for pain control, we can give steroid and local anesthetic. Sometimes for symptom control, we can put gels into the knee, which are hyaluronic acid based. The problem with the hyaluronic acids is we know that they degrade with time. So their benefit is time dependent. So after a number of months, they degrade. There are a couple of products in the market under evaluation that have longer life than the hyaluronic acid injections. But there isn't enough evidence to support their use or to offer them to you on a widespread basis at this time. People often ask about stem cell injections. So stem cell injections, largely they harvest your bone marrow. But I've had a couple of patients who have come to us, and it looks like for the most part it's combined with a very high dose of steroid and local anesthetic, which I suspect is what they're getting the benefit from. It's not suited as something that's going to regenerate your cartilage if you've got bad osteoarthritis. It's not really on offer from any of the mainstream players, and I would caution you about proceeding to stem cell injection at this time. There is a small bit of a role for PRP injections, which is where they take your blood. It's plasma-rich protein is what the PRP stands for. They spin your blood down and then they inject it back into the soft tissues of your knee. For most patients in the room, steroid and local anesthetic is probably your best bet. So the NICE guidelines, corticosteroid injections should be considered as an adjunct to the core treatments of moderate to severe pain in people with osteoarthritis. That's osteoarthritis of the knee, obviously. People often ask, am I suitable to have keyhole surgery on my knee? So keyhole surgery is a knee arthroscopy. For the most part, unless you have symptoms of catching or locking, you are probably better to have an injection of steroid and local anesthetic into your knee, because the benefit is the same, and obviously the injection is a lot easier. We can give it in a day ward setting, and you don't need an anesthetic to have it. If you're having a knee arthroscopy, there are very good results if you've got a meniscal tear that is stuck in the middle of your joint, but your knee is otherwise in good condition. So most of those patients present with catching or locking. Now, if everyone in the room went out and got an MRI and we looked at them all, we'd be here for the night. But, you know, even if you have arthritis in your knee, you will have meniscal tears, but they will likely be degenerative meniscal tears, and they don't really benefit from shaving them away. So, you know, you might have an MRI report. The headline line in the report is, you know, posterior horn medial meniscal tear. But in reality, the diagnosis is osteoarthritis, you know, and the treatment is the same. So it's injection, the conservative measures discussed, and if that doesn't work, then you're on to knee replacement. In terms of invasive treatments for knee osteoarthritis, as I've said, you know, don't put a camera in to do an arthroscopic washout and debridement unless there is mechanical locking symptoms, and really true mechanical locking symptoms. And you can see that, you know, since 2008, when the guidelines were published on this, these are UK figures, the number of knee arthroscopies has fallen all the way down, okay, for that condition. So we still do lots of knee arthroscopies in younger patients, but we do very few in your age group. Now, we're always open to a discussion on a case-by-case basis as to whether a knee arthroscopy is appropriate. Sometimes in patients with symptoms of short duration, we do the knee scope when an injection hasn't worked, but we suspect you're not quite at the stage where you need knee replacement, okay? So you can still see that there's a small number of patients having knee scopes for arthritic indications as such. But, you know, the fall off over 15 years is quite startling there on the slide. So at the top rung of the ladder, it's knee replacement. So what we've got here is we've got a metal end that is attached to the femur. We've a tibial tray that is also attached to the femur, and we've a plastic insert. They can either be cemented into place, which is again the most common, or they can be uncemented or press fit, okay? And there is a slight switch now where some of them are press fit uncemented because we have better technology for cutting the bones, which I'll come on to in a few moments. A lot of these implants, the knees in particular, and at least you know, good portion of the hips are actually all made in Ireland, you know, in Limerick and Cork. So the implants are locally sourced. So here we are. So this is a 74-year-old lady, pain in the right knee for 3 years. It's worsening. She's a reduced walking distance. She's night pain. She's had a number of injections. The last gave no benefit. My general conversation with patients is, you know, if you're getting, say, more than 4 injections per year, you know, it's probably time to do something else. 4 injections per year would assume that, you know, you've got 6 weeks benefit and then probably 6 weeks kind of in reasonable pain until you come around to the next injection. So it's not necessarily a sustainable strategy unless you are keen not to have a knee replacement. So here's the x-ray, and again you can see that there's osteoarthritis, there's osteophytes here to the side, there's some sclerosis, and the joint space is a little reduced. There is an osteophyte here on the opposite knee, but it's not to the same extent. Now, it's not completely obliterated, so we'll have had a chat with this patient. We'll have explained that, you know, knee replacement has about an 85% success rate in all hands. So no matter who does it, that's, you know, the figure in the literature for the chances of it being successful. About 10% of patients will be unhappy with the knee replacement. It won't meet their expectations. And then about 5% have a complication. This is a healthy knee, so you can see knee well preserved, joint space well preserved. And certainly we'd be questioning whether this patient, if they had the symptoms, you know, if it's arthritis or if the diagnosis is something else. So they'd probably need an MRI scan before proceeding to consideration of a knee replacement. But we also have the advantage, obviously, of a lateral x-ray. And, you know, sometimes we just see the arthritis in the patellofemoral joint and the rest is well preserved. It's a different patient. This patient went on to have a total knee replacement, so that's what a total knee replacement looks like. This one is cemented into position. Looks well aligned, looks good. A lot of patients have pain only in the inner compartment of the knee or the medial compartment of the knee, and they can have a partial knee replacement. Partial knee replacements don't have as good an outcome as total knee replacements, and that's perhaps because it's possible to revise it to a total knee replacement. So some of them will get revised with time, but this might add 10 years to the other compartments of your knee. So it's an option for some patients or for low demand patients who've isolated arthritis just in the medial compartment of the knee. There are certain criteria that have to be met. You have to have, not too much arthritis in other compartments. One of the things that is new in 2023, the title of the talk wasn't just suggestive. There is some new technology, and we have robotic knee surgery has arrived in Ireland. So this probably was available in Cork for a number of years, but in the Dublin area broadly has only landed since the autumn of last year, or at least last summer. This is the robot that is in Dublin. It's currently only in Blackrock and the Beacon, sadly. In time, it will be available in more centres, and the cost of providing these will come down. But the robot, has a price tag of about €1 million. So it's placed by the company. It's not paid. The patients aren't paying for the knee replacement. You need a CT scan in order to get a robotic knee replacement, and it takes the alignment of your hip and your ankle and a number of landmarks around the knee. And then it gives you a plan for how to place the components. So it's called a robotic assisted knee replacement. It's probably best thought as a robotic alignment of the knee replacement components. With the technology that's on the screen, the balancing of the knee replacement, which is the soft tissue ligament balancing, still has to be done by the surgeon who's doing the operation. So it gives accesses, and some patients have lower limbs that are in varus. That's where you have bowed legs. Other patients have valgus type alignment. That's where their knees hit together but their ankles go out to the side. And with both of them, you get a very accurate realignment of the knee to a straight knee. You get excellent range of motion. You get minimal swelling. It gives you, this is the screen capture from the robot, so it gives you, the suggested cuts that you make. It positions the implants. It shows you how much bone you'll take away. So you get a really accurate placement of the components, and you can see it on the screen in front of you as to how it does. Now, it's not an X-ray. It's done with landmarks using probes. So this is what we see. It's taking, it's taking 8 millimeters off this area. It's taking 4 off the distal femur. It's suggesting the sizes of implants that are used. It's correcting the slope of the knee. So it's all within millimeters that we have it. And it's done with the robot with what they call discs on probes. So we put a probe on your femur, a probe on your tibia, and we use a probe to create a map of your knee. So you can see this is the mapping process over here. That creates a map of your knee from the CT scan that you've obtained preoperatively. And then we get a very accurate placement of the knee. And you can test the knee here. So you can see they're testing the knee, and the figures are changing, indicating the gaps that they get. So they're getting 19 millimeters, 16 millimeters on the inner aspect of the knee. So as I say, that is state-of-the-art technology. Beacon and Blackrock have it with certain operators. Okay, so we've used this week. So answered all the questions from this week. You make the bone cuts with the saw. The saw only allows you to cut at certain angles that are predetermined by the robot. And you can change the angle, so you can adjust where the cuts are. But it does give a really good outcome in terms of range of motion and swelling that the patients have after the surgery. So certainly I've been quite impressed by what I've seen. Like all new technologies, the literature will probably only be there in a number of years. as to whether this is the way forward. The technology will likely by then have evolved further. So it's a constant evolution, but it is impressive. The implants used for the robotic knee are the same implants that I standardly was using. So there is no change in the finished product of the knee. It's identical to what we had previously. So the robot's name is Mako, but it's probably, in terms of the soft tissue and the recovery, an excellent operation. Okay, so that's robotic knee replacement. So probably just a few more questions while you mull over the content of the talk. So when is the most optimum time to consider having a knee replacement, or what time or stage should you consider having a knee replacement? So I think, when conservative measures fail and it's interfering with your quality of life, so, it's correcting your weight, strengthening your muscle with physiotherapy, taking simple pain relief, educating yourself about the conditions, perhaps attending at a group class or, session. And when those measures fail, then is the time to have a knee replacement if it's interfering with your quality of life. So can't walk, can't sleep, struggling on stairs, changing the house in this overheated property market because you don't want to have a stairs. All of these play into it. I've had that one today. Is there an alternative to knee replacement? So the alternatives, I suppose, are the injection therapies, but you have to be cognizant that the injections are really only going to work if you're getting excess 3 months benefit from something like an injection strategy. We didn't really talk tonight about knee replacements that were done and unsuccessful. So I did say that 85% of knees are successful. Where there's an identifiable reason as to why the knee has failed, in other words, maybe it's too loose or too tight, there is a role for revision surgery, or if it's infected. If you can't identify a reason why your knee is painful, as in why your knee replacement is painful, then oftentimes it's not sensible to just have it revised to a different knee replacement. So you need to be able to identify what the cause of the knee failing is, okay? But there's certainly a cohort of patients, as I said, who have their knee replaced, but it doesn't meet their expectations, okay? So obviously the consent and preoperative discussion around knee replacement is really important. Another question is, what can be done with Baker's cysts? So Baker's cysts are cysts that are outpouchings of the joint capsule, typically at the back of the knee, and they can burst spontaneously. Now, oftentimes they are outpouchings through or alongside the meniscus, and they may be associated with a meniscal tear. Typically, it's the same strategies for conservative measurements. There may be a role for knee arthroscopy in some of those patients if the symptoms don't settle. Sometimes it's doing a knee replacement and the cyst will resolve because the meniscus is removed. One of the things that we don't do is go in the back of the knee and excise the Baker's cyst, and we often get asked that question. There isn't a benefit to that. It typically creates a mass of scar tissue behind the knee that limits range of motion. So then there was one generic question, I think, diagnosed with osteoarthritis, very painful toes and feet, and on Ixprom tablets. Any other recommendations for relief? That's probably slightly out, in terms of conservative measures, that's probably just slightly out of my wheelhouse. I would encourage you to have a conversation with your GP and just see if there are other anti-inflammatory medications that may be appropriate. It may be that your foot and ankle are arthritic changes, and seeing someone who specializes in that area may be appropriate. Some patients with knee pain will get foot and ankle pain or pain running down their anterior shin. And it can be due also to the alignment of your lower limbs. We talked about, the conditions where you've got bow-legged or where your knees knocked together. And both of those, will benefit from intervention in your knee, but you may also have a separate foot and ankle problem. I think there may be one more question. So we're seeing one here on PRP injections. helpful for end-stage osteoarthritis. And I think if you've got end-stage osteoarthritis, it is about a matter of finding something that works no matter what that thing is. So, you know, if you have benefit from steroid local anesthetic injections and it's sustainable, go with that. If it's hyaluronic acid and it's giving you a benefit, that's great. PRP isn't going to necessarily be better than one of those for end-stage arthritis. It could be tried, but I would probably encourage you to think about whether in fact you need a knee replacement. Knee replacement today is certainly more successful. It is better than it was in the 1980s. The components used last longer. I've shown you the robotic knee, and we're getting good outcomes with that. So, you know, sometimes considering the surgical option may be the most appropriate there. So I hope answers to those questions have helped. So I'm not sure whether we've more time or more questions or how long they go out, but
I don't think we will go on too long more, but if there's anything really pressing that you want to put your hand up and ask, we might take one or two questions. So we'll take two possibly. Okay, that lady there in the pink.
What's the lifespan of a knee replacement?
So the question there is lifespan of a knee replacement. Again, you know, 15 years would not be unreasonable, but we are seeing knee replacements that are 20 years and beyond with very little wear.
One for 17 years.
17. So you would probably find that you've limited enough wear in that if you had a plastic in it that was a later generation of plastics.
I'm one of your patients, by the way.
Oh, very good. And did I do it? I certainly didn't do it 17 years ago, I suspect. Hugh Smith did it, yeah, in Tala. Very good. And it's still holding in?
Yes, but I'm on the waiting list for a scan at the moment. I've heard nothing back.
Okay. Maybe you might give your details to Noreen and they might just pass them on to me. Would that be okay? And I will. It's in Tala, is it?
Yeah,
the scan?
my name is Deirdre Kelly.
Okay. So we might just capture the details on an email and I will follow up on that, okay? No problem.
There was one other lady on this side.
So always some people here to lobby. I thought you were going to ask, could you have the robot and take it home? But, no is the answer to that one, you know.
There's a lady on this side here.
Yeah.
Can I just add, that was my question about the unsuccessful knee I had done 4 years ago, and there's nothing wrong, you know, as you say, x-rays, there's no infection. Is there anything else? It's extremely painful after, especially on standing and walking, and I've been told there's nothing I can do.
So you've had it investigate, you know, there's a series of investigations that they will follow. I suppose they're out to see, is it infection? Is the pain from somewhere else, your hip or your back? Is the knee stable or unstable? And as I said, the evidence for revision of the knee replacement is best if you can identify a cause for it. If you can't identify a cause, the advice by and large is not to consider revision knee replacement. So probably what you've been told is sadly frustratingly correct. Okay, and there are a number of patients who could fill the room here who are probably unhappy with knee replacements that I and others have done. And it can be quite disabling. So I empathise with you, but the information you've been given may be correct if you've had the correct investigations. Now, obviously, behind everything in the literature and on the internet, there is a case-by-case basis, and meeting with the consultant will tell you whether a revision represents a good idea, I would think. Okay, sadly.
Thank you very much indeed. We'll take one more. One more. Right there.
I have rheumatoid arthritis.
Yes.
From my toes right up, hands back, right up my spine. But I'm on methotrexate for years, and I was wondering if there was any new treatment now.
So,
besides having to take methotrexate.
So I suppose the first thing in relation to methotrexate, that used to be a drug that people stopped at the time of surgery. So if anyone here is on methotrexate and going for hip or knee replacement surgery, the current advice is that you can remain on the methotrexate during the pre-op and post-op period, okay? So that's the first thing. In terms of it is in the wheelhouse of the rheumatologist to advise you as to what else there is. There are newer biological agents that have been evaluated, so some of them may be appropriate. It's probably worth checking in with a rheumatologist.
I'm in Blanchardstown, arthritis clinic, and I haven't had an appointment for about 3.5 years.
So
I have to go to my own doctor to get my bloods checked.
Okay, it's Professor Duffy, isn't it? Trevor Duffy is the rheumatologist. He's a man in demand, I suspect.
Well, I mean,
But
3.5 years is a long
it's a long time. So I definitely couldn't give you any advice from the podium on it. I think you'd have to talk to your GP and just see if they would be familiar with what might be appropriate. Absolutely.
It's nothing to do with you. I know it's not your fault. That's the problem with people like
Absolutely, and certainly after the pandemic, you know, there was an enormous backlog. The HSE, to give credit, have tried in part to address it, and we have managed to bring down some of the urgent waiting lists for surgery through use of capacity in some of the private hospitals. There still are long waiting lists. If you have complicated medical history and are awaiting joint replacement, unfortunately, you know, sometimes they are the patients who are waiting in the university hospitals. The other thing is it is very much regional based, so you know, the information I'm telling you may apply to Tala, but not to Kappa and Connolly hospitals. So, you know, the waiting lists are longer in some areas, you know, so empathise with you fully on that.